The topic I will be presenting will be on community acquired pneumonia. I am Dr. Bensi Thomas, representing the team pulmonology. We'll start along with a case scenario where we had a 53-year-old male coming to the OPD who is coming from Alappuzha. He was a carpenter by occupation and is also a stage artist. And his main complaints were cough for 2.5 weeks, which was having a mucopurulent sputum. And he along with this he had one episode of fever and one episode of hemoptysis. Now he gives a history that he has taken 2 courses of antibiotics and he was not on any regular drugs. This patient actually, when I saw him in OPD, he was tachypnic, breathing for 30 times per minute, and pulse rate was 130, BP was on the safe side, and temperature he had a slightly variation of 99 °F, and he was normal, having a normal BMI, and he didn't have any pallor, icterus, there was no clubbing, no pedal edema, and no palpable lymph nodes over his neck or groin. And on his examination of the chest, it revealed a biphasic fine crackles, which was heard mostly in the right infrascapular area and interscapular area. Now, this is his X-ray. If you take a closer look, you'll be able to see that in the right side of the X-ray, the right side of his hemithorax, you'll be able to see a heterogeneous opacity, mainly occupying the lower zone. Heterogeneous opacity mainly occupying the lower zone. And we further took a CT chest which revealed a consolidation patch. Now, how will we come to the conclusion that he's having a consolidation on a radiology basis is that if you take a closer look, you will be able to see a whitish patch having black margins in between. These are known as air bronchograms, where along in a consolidation field, if you have a patent air bronchus, it is known as an air bronchogram. So this also supported to a diagnosis he is having a consolidation. Now coming on to his lab diagnosis, we were able to see that he was having a elevated total counts of 18,800, which was mostly 86% of polymorph predominant, and he was having anemia. His HD was only 10.7, and everything supported a pneumonia. Now, the thing that we found out for the first time was that he was not diagnosed to have any diabetes or any sort of immunocompromised condition till he visited the lab, and his labs revealed that his urine sugars were 3+, and he had an elevated blood sugars. Now we have sent this sputum, which will be discussed later by the microbiology team. So this was our final diagnosis. When you always come to a diagnosis, you'll have to have a pathological diagnosis, an anatomical diagnosis, an etiological diagnosis, and if possible, a radiological diagnosis. So our final diagnosis was a right lower lobe consolidation, which was a community acquired pneumonia because he acquired it from the community. And his etiology was he was having a type 2 diabetes mellitus. Now coming to the proper definition, how will you define community acquired pneumonia? It is actually a pneumonia which a host acquires from the community, and it is an inflammation and consolidation of lung tissue due to an infectious agent. Now we can define pneumonia based upon a radiographic evidence and without a radiographic evidence and with a radiographic evidence. Now without a radiographic evidence, the patient is having symptoms of acute lower respiratory tract illness for less than 1 week, and he should have at least one of the systemic features, which is temperature of more than 37.7 degree, either chills or rigors or severe malaise. There should be a new focal signs in the chest, which is commonly a bronchial breath sound or a crepitations or crackles, and there is no other explanation for the illness. Now, with a radiography, all the symptoms that we mentioned in the previous slide, along with the new radiographic findings in an X-ray or a CT, which we see, where we cannot explain, there is no other explanations. Now, based on a history, we can anticipate that these are the organisms, because a physician should always be involved in how this patient got, not only diagnosis, but the etiology. Now, if the patient gives a history of alcoholism, these are some of the common organisms which we can anticipate. The Streptococcus pneumonia, anaerobes, Klebsiella pneumonia, Acinetobacter species, and the Mycobacterium tuberculosis. And if the patient gives a history of COPD or smoking, the most common organism that one should anticipate is the H. influenza, Pseudomonas aeruginosa, Legionella. Rest of the organisms can also be seen in the COPD patients. If the patient gives a history of aspiration, either he had a bout of, had a pint of alcohol and slept somewhere or had a vomiting, now you can expect some gram-negative pathogens and anaerobes. And if the patient is having lung abscess, you can find MRSA, oral anaerobes, endemic fungal TB, and atypical mycobacteria also. The patient is having an HIV. Early phase, the patient always has, most of the patients have organism of Streptococcus pneumonia, H. influenza, and Mycobacterium tuberculosis. And it has been studied that in the late phase, patient develops with Pneumocystis jirovecii, which is the most common organism. Now, the usual presentation of the pneumonia will be the patient will be having a fever. And if the patient presents along with fever a hypothermia episode, always keep in mind that the patient is having a very poor prognosis. And sometimes the patient, as this patient, when he presented to the OPD to me, he didn't have fever at that time. Now, what will you look for? Always count the respiratory rate for at least a minute, not the usual 15 seconds or 13 seconds. You have to wait for 1 minute and check the respiratory rate. And on examination, always check for the dullness, which will be dull on percussion, which will be dull on percussion, and also the bronchial breath sounds you'll be able to hear along with crepitations or crackles. The vocal fermitus and vocal resonance will be increased because your underlying lung has become solidified rather from the normal architecture. And also one special sign you will be able to elicit, which the examiners mostly will ask, will be or they will be expecting a WPQ or a whispering petroleukin, and always expect a pleural rub in such patients. Now, how will we decide when to admit this patient or not? Now, there are many scoring systems, but the most common scoring systems which we follow is the PORT system and the Curve 65. Now, this is the PORT system, which is a rather having many indications. Like there are many scoring points and all, which will be very hard for you to memorize. But this is a very common thing. There's a Curve 65 scoring system where you can classify the patient with having confusion, whether the patient is having urea, which is more than 7 millimoles per liter. How to convert millimole to milligram will be, you have to multiply 1 millimole will be approximately 18 milligram per deciliter. And count the respiratory rate. This will be one scoring system where the respiratory rate will be more than 30, and blood B stands for BP, blood pressure. If the systolic is less than 90 or less than 90 and diastolic is 60 or less than 60, and the patient is having age of 65. Now, based on any patient with pneumonia, it is a rule to classify which category will he fall. Is he falling into the high risk, low risk, or the medium risk? So based upon this scoring system, you will be able to assess his mortality rate, and also you will be able to come to a decision whether to admit this patient or to send him home. Now, these are some of the complications you get in pneumonia. First and foremost will be the parapneumonic effusion. Along with the pneumonia, you'll be having an effusion, a meningitis, arthritis, endocarditis, empyema, where you'll be expecting pus in the pleural space, peritonitis, cavitation, some abscess, and in special case of pneumothorax, there will be special case of staphylococcal pneumonia, you can expect pneumothorax. One more common thing will be complication will be an ARDS. The patient will go for an acute respiratory distress syndrome. Now, these are the indications. The antibiotic therapy, you should be having a strong stewardship of antibiotics when you are treating a case of pneumonia. If you have decided that the patient is having, if you have seen that the patient is having a low curve score and you decide to send the patient home, the most common antibiotic which we can recommend is be a macrolide, and the doxycycline will be weak recommendation. If the patient is having comorbidities along with the comorbidities like malignancy, and he has used antibiotics within the last 3 months, you can go for a fluoroquinolone only if you do not consider him to have tuberculosis. Always rule out tuberculosis, then only start to decide whether you want to add fluoroquinolone, or you can go for a beta-lactam and a macrolide. Now, you have admitted the patient in non-ICU setup. The recommended antibiotic will be beta-lactam plus an macrolide. And if he's having hypersensitivity to beta-lactam, then there is no harm in using a respiratory fluoroquinolone like a levofloxacin. Now you have admitted the patient in an ICU setup. The recommended antibiotic will be beta-lactam plus macrolide if you are not considering a pseudomonas. As I said in the previous slide, if you are considering any pseudomonas like an alcoholism and all, it's better to start on an empirical antibiotic like an anti-pneumococcal anti-pseudomonas like a piperazine, tazobactam, cefepime, imipenem or meropenem. Along with that, you can add a respiratory fluoroquinolone or the above mentioned beta-lactam with an aminoglycoside or azithromycin. Or if you are considering an MRSA, you can add vancomycin or a linezolid. Now, what are the causes of a non-resolving antibiotic? You started on empiric antibiotic, you got a culture report, and you have started the antibiotics or changed the antibiotics according to the reports. Now, what are the causes of a non-resolving antibiotic? Non-resolving pneumonia is first and foremost, always consider whether you have diagnosed it as correct or not. Second thing, you have got an incorrect microbiological diagnosis. Third thing, if you are expecting again a pneumonia recurring in the patient or having non-resolved pneumonia, always do a bronchoscopy or check his bronchus whether he is having any lesion. Distal to this lesion, he is developing, whether he is developing any pneumonia. And always look for patient having no immunocompromised states, look for some other immunocompromised states like you have to send a serum for IgE, IgG and all. Now, these are some of the again and non-resolving pneumonia.
Bronchial obstruction, bronchiectasis, getting causes of non-resolving pneumonia.
Recurrent pneumonia. Now, the causes of recurrent pneumonia again will be the patient is having a bronchial obstruction. Check for the bronchus patency, do a bronchoscopy. Another thing is that take a CT and see whether he's having any bronchiectasis occurrence. Now, that's a permanent, irreversible dilatation and destruction of his bronchies. And always there is a possibility whether he's having a possibility of a sequestration. That is a part of the lung which is not having any contact with the air part. That is the patent airway part or with the circulation part.
For drainage.
For drainage. And another part will be any immunocompromised state we have to rule out. Thank you.
Thank you, Dr. Bensi. That was an excellent presentation. I think we'll go to the next presentation, that is pathology of pneumonia. We'll take questions to Dr. Bensi at the end of the session. Students, keep your answers, keep your questions to Dr. Bensi ready. We will take questions in the chat box. Okay. The second topic of the second MBBS class will be taught by dear Dr. Dalia Joseph. Dr. Dalia Joseph has done her MBBS from China Free Georges University. She subsequently did her MD in pathology from Narayana Medical College, Nellore. She is currently working in the capacity as assistant professor in the Department of Pathology at Believers Medical College. We request the students and attending faculty to please make this class an interactive session. If you have any questions, please put it in the chat box. So, dear Dr. Dalia, and Dr. Sherin, who is going to take the microbiology, we are very honored to have all of you young, smart faculty to be with us. Thank you, Dr. Dalia. Please, mic over to you. I'll put it on. Thank you.
Thank you, ma'am. Good morning, all. As the time is limited, let's quickly recall the normal anatomy and histology of lung. We know right lung has 3 lobes, left lung has 2 lobes. Sorry. Now, as bronchi enters the lung, it splits itself into smaller airways called bronchioles, which ends in alveoli. Alveoli are very tiny cup-shaped air-filled structures that are lined by pneumocytes surrounded by a meshwork of capillaries. Here is the microscopic view of normal lung tissue, where you can see the bronchiole, alveolar ducts, alveolus, blood vessels, and capillaries. Let's take a closer view of this area, where you can see pulmonary alveoli filled with air, lined by alveolar epithelium, which on closer view shows lining by type 1 and type 2 pneumocytes. You can also appreciate the alveolar macrophages containing anthracotic pigments. Moving to the topic proper, how do we define pneumonia? Any infection of lung in an healthy individual acquired from normal environment is defined as pneumonia. It may be bacterial or viral. So how does this occur? Initially, we obtain an upper respiratory tract viral infection, following which a bacterial infection occurs. This causes bacterial invasion of the lung parenchyma. So once the bacteria invades the lung parenchyma, we know our alveolar macrophages will go and destroy them. But in pneumonia, there is uncontrolled bacterial proliferation. Can you tell me why? It is because the normal defense mechanism of our respiratory system, like our respiratory tract epithelium, alveolar macrophages, mucociliary escalator, even the IgA antibodies within the mucosa, these gets compromised due to certain conditions like diseases in like cystic fibrosis, due to smoking, due to aspiration, etc. So because these get compromised, there is uncontrolled bacterial proliferation, so much that our alveolar macrophages alone cannot control them. So what they do is they will release inflammatory mediators called cytokines, which will cause influx of inflammatory cells into the alveolar space. It will also elicit an inflammatory response. So now within the alveoli, we are having numerous inflammatory cells like neutrophils and alveolar macrophages, which together will destroy the invaded bacteria. Another mechanism is these bacteria, they release certain toxins called endotoxins, which will cause direct injury to the alveolar epithelium. Again, this will cause inflammation and release of inflammatory mediators like cytokines and chemokines, which will cause the surrounding vessels to dilate as well as increase its vascular permeability, thereby causing further influx of inflammatory cells and RBCs into the alveolar space. So the net effect of these two mechanisms, we now have an alveoli that is filled with inflammatory exudate, which is causing consolidation or solidification of the pulmonary tissue. Here is a pictorial representation of the entire step of pathogenesis in its most simplified form. Now, we know there are two patterns of bacterial pneumonia. Can you tell me what they are? Yes, bronchopneumonia and lobar pneumonia. First, we will talk about lobar pneumonia, then we will move on to bronchopneumonia. Lobar pneumonia, as the term indicates, is consolidation of a large portion of lobe or entire lobe of lung. Like we see here, this is the affected lobe and here you can see the normal lung. The pathology of lobar pneumonia is divided into stages based on its inflammatory responses. So can you tell me the pathological stages of lobar pneumonia?
Stage of congestion.
Excellent. First comes the stage of congestion, where our lungs are heavy, congested, having a reddish appearance like you see here. In this stage, you will see there is edema fluid, plenty of bacilli and few inflammatory cells. Microscopy of this condition can show you pale eosinophilic edema fluid within the alveolar space. Inflammatory cells. After the stage of congestion comes the next stage, is the stage of red light. Here, because of this our lung, it loses its spongy nature. It becomes firm, hard, airless, having a liver-like consistency. Hence the term hepatization. Here it will be having a grayish red appearance. Hence red hepatization. Like the lung we see over here. Another picture where our lung looks like liver, resembles liver. In this space, within the alveolar space, you will be seeing massive exudates, that is neutrophils, along with RBCs and fibrin. Now, where did this fibrin come from? It is the edema fluid that is getting replaced by fibrin strands. So under microscopy, you will be seeing congested capillaries and alveolar spaces filled with inflammatory exudates. Another picture where you can see the edema fluid getting replaced by fibrin strands, inflammatory cells and congested capillaries. Following this stage comes the third stage, that is the stage of gray hepatization, where our lungs continue to remain solid, firm, airless. From its previous reddish appearance, it will become grayish white in appearance, hence the term gray hepatization. Like we see over here, this is the affected lobe. Another picture where the normal lung as well as the affected lobe has been demarcated for you. In this space, the neutrophils, they start getting replaced by macrophages. There is disintegration of RBCs and persistence of fibrinosuppurative exudates. Now, as time passes, this fibrinosuppurative exudate, they undergo enzymatic digestion and convert themselves into a granular debris that is semi-fluid in consistency. This granular debris, it either gets ingested by macrophages or reabsorbed by them. It may get expectorated out via cough or it may get cleared by lymphatics. By these mechanisms, our alveoli now appears nearly normal, restoring the aeration of the affected lobe. That is the stage of resolution. This is the final stage where our alveolar spaces look nearly normal. Under microscopy, you will be seeing air in the alveolar space with very few macrophages and inflammatory cells. One must also keep in mind that this fibrinosuppurative exudate may undergo organization by fibroblasts proliferating within it. So to summarize, the stages of lobar pneumonia involves stage of congestion, red hepatization, gray hepatization, and finally resolution. The other pattern was the bronchopneumonia. As we know, in bronchopneumonia, there is patchy consolidation, which may involve one lobe or many lobes. They are usually bilateral and basally located, and grossly they appear as irregular, granular, yellowish lesions like the ones demarcated here. Can you identify them here? These areas, these irregular lesions. So when we look at the microscopy of this consolidated area, you will be seeing massive exudates within the bronchi causing acute bronchiolitis, Within the alveolar spaces causing leukocytic alveolitis, there will be marked vascular congestion, and the surrounding air spaces will be alveolar spaces will be distended. While in lobar pneumonia, we went through phase of congestion, red hepatization, gray hepatization, and finally resolution. I think with that we'll conclude here. Thank you.
Thank you, Dr. Dalia. That was an excellent presentation. We went through all the stages of pneumonia, exactly going to second MBBS classroom. I request Dr. Sherin to continue with Dr. Dalia. Exactly what was the organism which was isolated from Dr. Bensie's sputum and blood cultures. Dr. Sherin Susan Abraham is Assistant Professor in Microbiology in Believers Medical College. She will talk all about the bug which caused the community-acquired pneumonia. The class on Streptococcus lab diagnosis of pneumonia. This will Dr. Sherin did her MBBS from Vinayaka Mission College Research Center, Karaikal, Puducherry. She did her MD in microbiology from Sri Venkateshwara Medical College and Research Center in Puducherry. And she is now working in the capacity of Assistant Professor of Microbiology in Believers Medical College. We request again the students that if you have any questions, switch your personal mic and please keep it in mute form if some of you have put on your mics. Okay, we'll have all the questions there. Okay, over to you, Dr. Sherin Susan Abraham.
Good morning, students. I'm talking on the lab diagnosis of pneumonia. So we got a sputum sample from the patient, which was described in the clinical scenario, and from the sputum sample we did a gram stain, and gram stain showed pustules which were more than 25 per low-power field. Epithelial cells were 0 to 5 per low-power field, and microorganisms were seen, moderate gram-positive cocci in pairs, and few gram-negative bacilli were seen. So this is a gram stain image where you can see more numerous pustules and gram-positive cocci. That is a diplococci, gram-positive cocci in pairs, and these were the microorganisms. You can see numerous gram-positive cocci in pairs. It is a diplococci. So coming to the quality of sputum sample, how to assess the quality of sputum sample? That is by a scoring system called as Bartlett score. So this is a scoring system where there are many different grades depending on the number of pustules and epithelial cells. And for an ideal sputum sample, good sputum sample, the pustules has to be more than 25 per low-power field and epithelial cells has to be less than 10 per low-power field. And the Bartlett score for this sample was +1. That is, the sample was a good sample for culture. So here you are seeing two images. The first image is a blood agar, image of a blood agar where you can see alpha hemolytic colonies. That is, you can see some greenish discoloration around the colonies, and the typical appearance is the carom coin shaped or Drotsman shaped colonies. The second image is a chocolate agar where you can see the pneumococcal colonies, greenish colonies you can see. With because it's a sputum sample, you're also seeing the normal upper respiratory flora along with the pneumococcal colonies. So now you have seen the culture images. Now we have to do the identification test to identify the organism. Now the first test is the Octochin test. So Octochin, pneumococca is sensitive to Octochin. So in the around the disc you can see a wider zone of inhibition. So Octochin is sensitive, and Bile solubility, next is a bile solubility test. You are seeing two test tubes. In the second test tubes, you are seeing clearing, and the first test tube it's turbid. So there is an enzyme which is produced by pneumococci, that is the autolysin. Autolysin, the property of autolysin is the autolysis of the pneumococcal cells, and this action is enhanced in the presence of bile. So pneumococci are soluble in bile. That's why you're seeing a clearing in the second test tube. Whereas other streptococcal species like viridans, they're not soluble in bile. Okay. Now, oxacillin disc. You're in the first image, you're seeing the oxacillin disc. You're seeing a zone around it. That means oxacillin test is done for antibiotic sensitivity. If you're seeing if the oxacillin disc is sensitive, then you can report the drugs like penicillins and cephalosporins as sensitive. If the oxacillin if a disc shows resistance, then the MIC of penicillin and cephalosporins like ceftriaxone, cefotaxime has to be tested separately with MIC test. Now, this is the next identification test, the quelling reaction, where where the type-specific antiserum is added along with the dimethylene blue, and you can see the capsular swelling around the organism. Now coming to the different serological types, there are more than 90 capsular serotypes for pneumococci, among which 23 serotypes are responsible for bacteremia and meningitis. An antibiotic sensitivity test is done by the method Kirby-Boyer disc diffusion method in blood agar, and the drugs tested were penicillin, erythromycin, clindamycin, ceftriaxone, levofloxacin, linezolid, vancomycin, all were found to be sensitive. And we have reported few penicillin resistant strains from the respiratory samples in our laboratory. And the penicillin resistance is mainly due to the penicillin binding, alteration of the penicillin binding proteins. Now, the other infections caused by pneumococci are invasive and non-invasive infections. Non-invasive infections are bacteremia, meningitis, peritonitis, osteomyelitis, and non-invasive infections are otitis media, keratitis, and sinusitis. Now coming to the prophylaxis, there are two vaccines. First one is a 23-valent pneumococcal polysaccharide. It's a polysaccharide vaccine, and it comprises of the 23 serological types. And the indications for the vaccine are splenic dysfunction, asplenia, chronic lung, liver, kidney disease, cochlear implants, sickle cell disease. And the second vaccine is a conjugate vaccine, 13-valent polysaccharide conjugate vaccine, and this contains 13 serological types of pneumococci, and this is a vaccine which can be given for children less than 3 years of age. Now, what are the etiological agents of community-acquired pneumonia? Streptococcus pneumoniae, Haemophilus influenzae, Mycoplasma pneumoniae, Chlamydophila pneumoniae, and the viral agents are influenza virus, parainfluenza, adenovirus, SARS-CoV-2, respiratory syncytial viruses. So community-acquired pneumonia is acquired from the community setup. Next is the hospital-acquired pneumonia, acquired from the hospital setting after 24 to 48 to 72 hours after admission of the hospital, and it's mainly by the aerobic gram-negative Bacilli, Klebsiella, Escherichia coli, and Pseudomonas and Staphylococcus aureus. Now, to summarize, the case discussed today was a case of community-acquired pneumonia, and it was confirmed by microscopy and culture, and the strain was sensitive to penicillin. Thank you.
Thank you, dear Dr. Sherin Susan Abraham. The session is open for the audience. If you have any questions, please put it in the chat box. Next on the agenda is a rapid fire quiz on the topic pneumonia by Dr. Benji Goikel Thomas. Yeah, next please.
No.
Audio we'll have all the, okay, we have a question from the audience. What are the manifestations of pneumonia in patients with COPD? Is there any special manifestation? How will you know? They will anyway come with acute exacerbation.
Most of the COPD patients, the definition for COPD will be having that they are having permanent and irreversible constriction of their bronchi. So they will be always having a baseline cough and breathlessness and all. And we always give them a recommendation that we always recommend that you have to seek any medical advice if you are having some variation from your baseline breathlessness, like you are more breathless than your usual pattern, you are having sputum quantity more than what you had in the previous days, and also if you are having any constitutional symptoms, like you are feeling tired, you are feeling lethargic, you are having fever, you are having a loss of appetite and all, which gives us an indirect clue that the patient is having a exacerbation of COPD. The most common cause of an exacerbation of the COPD will be a bacterial pneumonia. So in such patients, there is no any special manifestations of pneumonia other than patient be having fever, cough, he will be producing a mucopurulent sputum, constitutional features, and also such patients who are elderly will be also having an hyponatremic symptoms. So these are some of the pneumonia symptoms that you can expect in a COPD patients.
Okay, sir, and the management would be similar only.
The management of a COPD patient having a pneumonia will be the same thing which I had described in the slides previously regarding the antibiotics, and also here we have to give special consideration of adding bronchodilator also along with the antibiotics.
Next question is to Sherin ma'am. What is Bartlett's score? Will you describe Bartlett's score?
So Bartlett score is a scoring system to assess the quality of the sputum sample. When you see it under microscopy, how good the sputum sample is for culture. So you have to see the number of pustules and quantity of the pustules and epithelial cells. And this Bartlett scoring is mainly going to depend on the number of pustules and epithelial cells. Pustules has to be, for an ideal good sputum sample, the pustules, that is inflammatory cells, has to be more than 25 and the epithelial cells has to be less than 10. And there are various grades based on this, that is based on the number of pustules and epithelial cells, like +1, +2, and -1, -2, 0, depending on the numbers of the epithelial cells and pustules.
What is higher beneficial for
Is
patients with COPD?
Is
Is antibiotic prophylaxis beneficial in pneumonia? That's two things.
One more question that I received, that is that in a pneumonia patient, is an antibiotic prophylaxis beneficial to patients who are prone to, I think, what
So
they are
with
COPD patients, yeah.
For a long time.
The COPD patients and all, these people come in the category of the patients who are having a low immunocompromised condition, or they are having a low immunity patients. So in such patients, we do not recommend any prophylactic antibiotics, but always we recommend a prophylactic vaccination, which we had seen in the microbiology slides, that there are two types of vaccination. In fact, one will be the pneumococcal PSV, the pneumococcal vaccination, which is having the 23 type of serological types, and which we recommend the patients with COPD to get one shot once a time. Then after 5 years, they'll have to take a second shot. So you take a pneumococcal vaccination one time, then every 5 years you have to take the vaccination again. The second vaccination will be the influenza vaccination, that is the viral vaccination, and also which is recommended in such populations, which they have to take a vaccine shot every year. So other than this, we don't recommend any prophylactic antibiotics. One thing is that along with this, I would like to add now macrolide, which we find helpful in such patients like COPD or pneumonia patients. In a COPD patients who is prone to get more and more, especially Pseudomonas colonization, we give them a prophylactic, rather than a prophylactic, we give them an anti-inflammatory dose of an antibiotic, that is the macrolide, or the common thing is the azithromycin. We give them a 250 milligram, which the patient can take every alternate day for at least 6 months. Now, this is not a prophylactic antibiotic dose, but this is given as a dose of anti-inflammatory dose.
To prevent biofilm formation. So I think due to short of time, we are going to the quiz only straight away. Now, quiz will answer a lot of questions. Now, we'll ask you the question, you answer. Okay, continuing. Yeah, audio is on only. Now we will answer in the chat box. Please answer fast in the chat box.
So I think you are ready with the MCQ. For the MCQs, the first question will be: now a patient presents with chest pain due to aspiration pneumonitis. On examination, he is having dullness on percussion on an area medial border of the scapula on elevation of the right arm. Now, which part of the lung is most likely affected? Do you think? Is it the right superior lobe? Is it the right posterior lobe? Is it the left superior lobe? Or is it the right apical lobe?
Only 2 seconds. We answer very fast. A, B, C, or D? First. So
now we got answer that the patient. Some of you have answered that the answer is
B.
B.
We are
so
all
right
as B.
B. Posterior lobe.
Suman, Anjusha, Dari, Rachel, John, Asha. Everybody saying B. Sir, what is the answer, sir?
It's actually the right superior lobe. It's not the right posterior lobe. So this is the anatomical surface marking. Like you raise your arm, your medial border of the scapula will be correlating with the oblique fissure, and whatever comes above will be having the superior lobe, and below will be the posterior lobe and the lower lobe. My question was, where you are getting a dullness on elevation of the right arm in the medial border of the scapula. No, it correlates with the right superior lobe. So answer A is the correct answer.
A is the correct answer.
Now coming to the second question. In actinomycosis, the sulfur granulomas which you see in actinomycosis are composed of what? Are they monocytes? Are they neutrophils? Are they lymphocytes? Are they eosinophils? Or are they organisms? The sulfur granulomas that you see in actinomycosis are composed of what? Is it monocytes, neutrophils, lymphocytes, eosinophils, or the organisms?
2 seconds, be fast. Sir, actinomycosis can affect lung, it can affect the foot.
Now we have got an answer that the patient is
E, C, A, D.
A, D. Okay, we go for the answer. The answer is the organism. E is the correct answer. Actinomycosis is the flora which you see in the oral cavity, the normal gut, and the genitourinary tract. Now, patient is E. E is the answer. Coming to the third question. 64-year-old male who is an ex-smoker comes to the clinic with breathlessness for last 1 month. Now, he gives a specific history that he cannot keep up with the pace of his friends while going for their morning walk. Now, what will you recommend will be his grade of breathlessness? That is the Modified Medical Research Council, MMRC. Grade of breathlessness will be 0, 1, 2, 3, or 4.
He cannot walk with the pace of his friends. His friends are how old, sir?
Same friends. All of them are retired from the army, and all of them go for a morning walk, and he cannot keep up with the pace of the friends. Okay.
So B, C, mostly C, then B also. Some people answering B.
Okay, we got an answer. It is C, and some have answered it is grade 1. Now the answer will be grade 2. C is the correct answer. So this will be the MMRC. The patient cannot walk with the people of the same age group. He cannot keep up with the pace and correlates with the grade 2 MMRC. Next question. Xilutol, the drug Xilutol is used in asthma, but it belongs to which group? Is it a leukotriene antagonist? Is it a lipooxygenase 5 inhibitor? Is it a mast cell stabilizer, or is it a monoclonal antibody? The drug Xilutol.
So that is a difficult question, sir. We don't use it so commonly. What is
it? It is not commonly seen in the markets today. It was there once. You can take a wild guess.
So we don't know.
Okay. So the question goes, it's actually a lipooxygenase inhibitor. Answer is B. Lipooxygenase inhibitor. Now this is your mechanism of action in asthma. You can see the mast cell or the eosinophil. coming to the arachidonic acid, and 5-lipoxygenase will convert it to the leukotrienes. So here it acts to inhibit the lipoxygenase pathway. Your usual montelukast, zafirlukast and all act in the second pathway. It is the LT inhibitor.
C. Some people have written C. AC.
Okay.
Next question.
Okay. So the next question will be, now a spirometry, which you have done in your physiology labs while you were in the first year. The spirometry can demonstrate and measure all except your tidal volume, the total lung capacity, vital capacity, or the inspiratory reserve capacity. You do a spirometry and you get all, but among these 4 options, one of the values you will be, or one of the capacities or values you will be not able to get in a spirometry. Which is this?
The answer is B by all. Rachel, Hari Krishna, Asha.
Right.
Jay.
Everybody has answered is the total lung capacity, which is the correct answer. Because in order to get the total lung capacity, you should have the residual volume, which you are not able to demonstrate in a spirometry. You will have to get a plethysmography. Now your first year question. A surfactant is made up of mostly what? Is it fibrin? Is it phospholipid? Is it a mucoprotein? Or is it a fibrinogen? Your
The
surfactant.
answer is B by everybody. Dari, Maria.
Okay, everybody has answered. Most
Exactly.
of the people have answered this as B, and it is correct. It is the most common organism or most common thing that you composed of a surfactant is the phospholipid.
So B is correct, sir.
Yes. Now the drug of choice for PCP, or now it is known as PJP, pneumocystis jirovecii pneumonia, will be what? Is it clarithromycin, clindamycin, cotrimoxazole, or cephalosporin? The drug of choice for pneumocystis carinii pneumonia, which is now known as pneumocystis jirovecii pneumonia.
They are all saying C, sir. Dari, Meda, Darwin.
Okay, mostly I have answered is C, and the correct answer is
Irene.
C. Correct answer is C. It is cotrimoxazole. Friedlander's pneumonia. It is caused by what? Friedlander's pneumonia.
So that's a difficult question, sir.
Caused by which organism? Is it a streptococci, staphylococci, H. influenza, or Klebsiella pneumonia?
So they are all saying D.
Yes, Friedlander's pneumonia. Other name is Klebsiella pneumonia.
But they are reading, sir.
Klebsiella pneumonia is one pneumonia where you will be having a recurrent jelly expected in the sputum. The sputum or the hemoptysis will be recurrent jelly type, and you will be having a lobar pneumonia mostly.
Which means students are reading, right?
Or with the Google. Now,
Or with Google also they can answer. That's not
which
fair.
among the following is definitive host in the life cycle of toxoplasmosis? Definitive host in life cycle of toxoplasmosis. Cats, dogs, crabs, or humans?
A, they were there.
Cats is the right answer. Cats is the definitive host of feline class of animals is the definitive host of toxoplasmosis. Now the last question will be the mechanism of action of penicillin. Will it bind to a 50S ribosome? Will it inhibit the DNA gyrase? Will it inhibit the protein synthesis, or will it inhibit the cell wall synthesis? Mechanism of action of penicillin.
They have answered D, sir.
Yes, it is the right answer. It inhibits cell wall synthesis.
Yes. Sir, I think that's it for today. I think one student, Anna Matthew, has raised a hand. Do you want to say a few words? Anna, you can unmute and say what is the question you wanted to ask? Anna Matthew, you wants to ask a question? Sir, how many patients have you seen parapneumonic effusion? Is it very common?
It is a common thing. Like most of the patients where we get an effusion, when we go back to the history, these people will be having pneumonia symptoms for the past 1 or 2 months. Recently, we had 2 patients, which I had in fact put on a slide, but it was not clear. Now, these patients had pneumonia for 1 to 2 months, and they were neglecting the symptoms. they were taking the over-the-counter medications for gastritis, and finally they ended up with an effusion. And by the time we put the intercostal drainage tube or a tube thoracostomy, we were able to see pus coming through them. Now, these people belong to the middle age group, not to the elderly or not the pediatric group. So we see a middle-aged people group coming with the complications of pneumonia. And most common complications that we have come across is an effusion or an empyema.
But pleural effusion, a mild pleural effusion is seen in some people. But
In some people.
Okay. So then, the commonest pneumonia is streptococcal pneumonia, which is the commonest organism which you can see. Okay. Then viral pneumonias, which is the commonest which you can see. Nowadays you see COVID pneumonias, but H1N1 pneumonia is also
H1 pneumonia and H1N1, while during 2018, end of the 2018, we had got most of the.
So what is the dose of neuraminidase inhibitors you give in H1N1?
It's actually the oseltamivir.
75 milligram twice a day for 5 days.
5 days.
And this drug, remdesivir, what is the dose you would give?
Remdesivir will give the usual
400 milligram stat and
200 BD.
BD for 5.
At least 5 days.
5 days. Okay. So an aspiration pneumonia would add metronidazole.
In aspiration pneumonia, one thing that you have to expect is an anaerobic organism. Always better to add a metronidazole, but if you are adding only single drug, if you are expecting an aspiration pneumonia, patient is having lung abscess or an aspiration pneumonitis or aspiration pneumonia, one drug we can give for all that covers will be a clindamycin. That will be a very good drug, which we can give the patient on oral basis, and we can tell the patient to take it from home. Once you have completed the IV dose, we can tell the patient to take an oral clindamycin for at least 14 days, 10 to 14 days. So clindamycin will be drawn to, but actually speaking, you have to start a metronidazole as soon as you expect patient is having any anaerobic.
Mycoplasma pneumonia, sir, do you think that is common?
Mycoplasma pneumonia organism as such, we are not able to.
Unless patient presents with lymph nodes or something. And Legionella pneumonia?
Legionella pneumonia we can expect in patients who are the elderly group.
And children who are less than 3 months
Children
old.
who are less. But here we do not usually do the urinary antigen for the Legionella cost-wise. So, but on a routine basis, we always ask we had shown in the previous slides and all, like patient, whether he is coming on an outpatient basis pneumonia or you are treating him an inpatient, you are adding an azithromycin. So it covers of the Legionella part also.
Do you think, sir, gastric feeding tube is and proton pump inhibitors has increased the risk for pneumonia?
The risk of pneumonia, especially patients in the hospital-acquired pneumonia, one of the things that we are neglecting or we are not giving much importance is the proton pump inhibitors and the routine use of proton pump inhibitors. We have a habit of writing a proton pump inhibitor along after an antibiotic in our case sheets and all, but we do not know its consequence that it can produce. If you are expecting a gastritis, always a patient who is vulnerable to get a hospital-acquired pneumonia, you can substitute this proton pump inhibitor with a sucralfate, a simple sucralfate solution.
Yes, so that it increases overgrowth of gram-negative organisms in the stomach because of the low pH, and that's how you get an aspiration pneumonia. I think, Dr. Vinci, that was a wonderful presentation and of pneumonia. The class on pneumonia was really wonderful, and thank you, Dr. Sherin Susan Abraham, thank you, Dr. Dahlia, and thank you, Dr. Vinci. And I'm sure Dr. Renu Matthews, HOD of microbiology, was there online, and Dr. Ajita Kumari was also there online, and Dr. Elizabeth was also there online from pathology. And I think that it's exceeded the time, and so I think we should stop this session on pneumonia. And we really thank everybody for this wonderful academic session. And even Dr. Luke, I'm sure he is there on the line and listening to all of us. And we have similar academic sessions after the MedFest. We'll have a MedFest this next week, and so we have a short break for the integrated clinics in the next week. So next class is students is on December 3rd. So meet you next Thursday at 3:30 p.m. Till then, wishing you a wonderful week ahead. Till then, bye.